Hi, I'm Pratap. Today we'll study anti-diabetic drugs. Diabetes first described in writing by Hindu healers in 1500 BC, and the term diabetes was first used in 250 BC. There were many hit and trial methods to treat diabetes until some conclusive research found the role of insulin and pancreas. In 1921, insulin was discovered by Benting and Best, and Leonard Thompson was the first patient to receive insulin, and commercial production of insulin started by Eli Lilly with University of Toronto. In 1940s, diabetic complications began to occur, and there were also several deaths due to insulin-induced hypoglycemia. Until 1995, only sulphonylureas and biguanides were there, and now we have almost 12 groups of drugs. Most of the drugs today we have are discovered after 2005. So diabetes is a heterogeneous metabolic disorder characterized by hyperglycemia, which may be due to either insulin deficiency or insulin resistance. So this carbohydrate metabolism is interlinked with the protein and fat metabolism, and carbohydrates on digestion are produced to glucose. Glucose undergoes glycolysis to produce pyruvate. Pyruvate is converted to acetyl coenzyme, which undergoes Krebs cycle, and there will be production of ATP. Proteins and fats also can join. Proteins are digested to amino acids, and amino acids can be oxidized to pyruvate or acetyl coenzyme, and fats are digested to fatty acids, which undergo beta oxidation to form acetyl coenzyme. In diabetes, there is hyperglycemia, and also glycosylated hemoglobin level increases more than 6.5%, and due to hyperglycemia there can be glycosidia, polyuria, polydipsia, muscle wasting, elevated levels of free fatty acids and triglycerides, ketosis, ketonemia, and ketonuria. Diabetes can be of four types. Type 1 is insulin dependent diabetes mellitus, type 2 is non-insulin dependent diabetes mellitus, type 3 due to other causes, and type 4 is gestational, that is during pregnancy. Insulin is secreted from the beta cells of islet of Langerhans of pancreas in response to glucose. When glucose enters into the cell, there will be glycolysis and production of ATP, and ATP blocks the ATP sensitive potassium channel, which causes the depolation of the cell, and there will be opening of the voltage gated calcium channel, and that calcium causes exocytosis and insulin release. So insulin, how it acts: it binds to the insulin receptor, which is a tyrosine kinase linked receptor, and once it binds, there will be production of insulin specific MAP kinase through RAS-RAF pathway, and that insulin MAP kinase will synthesize, regulate the gene transcription, which leads to synthesis and recruitment of glucose transporter, and there will be also regulation of the genes responsible for enzymes involved in gluconeogenesis, glycogenesis, and glycogenolysis. In type 1 diabetes, there is destruction of the beta cells in the pancreas by immune cells, and it leads to absolute insulin deficiency. Type 2 diabetes can be either due to relative insulin deficiency or due to insulin resistance. If diabetes is not treated for a long period, it will lead to vascular complications, and that complications may be macrovascular or microvascular. Microvascular complications include retinopathy, nephropathy, neuropathy, and macrovascular complications include heart disease, peripheral vascular disease, stroke, etc. So we can manage diabetes by use of diet and exercise, or oral hypoglycemic therapy, or insulin. So when the glucose level increases, the body secretes three enzymes: insulin, incretin, and amylin, to decrease the glucose level. And when glucose level decreases, we have four hormones: glucagon, epinephrine, cortisol, and growth hormone to increase the glucose level. Ominous octet is proposed by D. Fronzo to describe hyperglycemia. And hyperglycemia occurs when there is impaired insulin secretion, increased glucagon secretion, increased hepatic glucose production, neurotransmitter like dopamine dysfunction, decreased glucose uptake, increased glucose reabsorption, increased lipolysis, decreased incretin effect. The current treatment options oral agents include biguanides, sulphonylureas, meglitinides, thiazolidinediones, alpha glucosidase inhibitors, GLP-1 agonists, dipeptidase 4 inhibitors, dopamine 2 agonists, bile acid sequestrants, SGLT2 inhibitors. The injected or parenteral medications include insulin, GLP-1 agonists, and amylin analogs. The devices can be made intelligent and used in diabetes for delivery of insulin. So these are called intelligent devices like pumps, pens, and it can have four components: the insulin delivery and one glucose sensor to sense the capillary blood glucose level. Then based on that sugar level, insulin delivery can be made. So that is glucose responsive insulin delivery, and finally that can be controlled by the patient himself or the healthcare professional. Sulphonylureas and glianides are the insulin releasers which act on the sulphonylurea receptor present on the beta cells of islet of Langerhans pancreas. By acting as agonist on this G protein coupled receptor, they block the ATP sensitive potassium channel, cause depolarization of the cell, open the voltage gated calcium channels which cause exocytosis and insulin release. Metformin decreases the hepatic glucose output by inhibiting gluconeogenesis and glycogenolysis, and it also increases the uptake of glucose in skeletal muscles and cause glycogenesis, and in intestine it inhibits the absorption of glucose. And this can be done at the molecular level inside the mitochondria by inhibiting the complex 1 of electron transport chain or the enzyme glycerophosphate dehydrogenase. Alpha glucosidase inhibitors are the oligosaccharide analogs which can inhibit the binding of the oligosaccharides with the alpha glucosidase enzyme present in microvilli of enterocytes in the GIT and inhibit their digestion. Similarly, another hexose monosaccharide D-tagatose inhibits the digestion of disaccharides like sucrose, maltose, and it also acts on liver to decrease the hepatic glucose output. Thiazolidinediones act on the nuclear receptor, peroxisome proliferation activated receptor gamma, and cause adipocyte differentiation, which results in increased uptake of glucose as well as fatty acids, and in they cause decrease in lipolysis, so there will be decreased free fatty acid levels, and they also increase the level of adiponectin, decrease TNF alpha and leptin, so that they can prevent insulin resistance and can improve insulin sensitivity. And in liver and muscle they can increase the uptake of glucose and free fatty acids. The peroxisome proliferator activated receptor are of three types: alpha, gamma, and delta. And gamma in white adipose tissue regulates the has a role in diabetes, and PPR alpha in liver has a role in hyperlipidemia, and delta in skeletal muscle has a role in obesity. So some pharmaceutical companies have developed PPA or dual agonists or pan agonists to be effective against multiple diseases including diabetes, but unfortunately the toxicity is more as compared to its beneficial effects, because of which these drugs have been stopped, their trial have been stopped. Then Gila monster, the saliva of Gila monster contains a chemical called exendin 4, which is released after food, and similar molecules called incretins are found in human beings, and they are GLP-1 and GIP, glucagon-like peptide 1 and gastric inhibitory polypeptide, and among these two GLP-1 is more significant. So, and this GLP-1 when the food comes enters the intestine, GLP-1 is secreted, and it acts on the pancreas to increase insulin secretion and decrease glucagon secretion. So this increases the insulin sensitivity, and all these insulin actions will be there. In the brain it acts as a satiety factor and decreases appetite, and in stomach it decreases gastric emptying and delay the digestion. However, it has cardioprotective effect, and this GLP-1 is degraded by the enzyme dipeptidyl peptidase 4. So DPP4 inhibitors can increase the level of GLP. So all these GLP-1 agonists and DPP4 inhibitors can be INCRETIN mimetics. The GLP-1 agonists are mostly parenteral, and just recently semaglutide, the oral GLP-1 agonist, has been identified. Amylin is co-secreted with insulin from the beta cells of islet of Langerhans of pancreas. So amylin analog pramlintide can be used as a parenteral drug for management of diabetes. Bile acids act on the bile acid receptors in the liver to induce gluconeogenesis. So bile acid binding resins like cholesevilam can be used as anti-diabetic drug. Again, there is a receptor called TGR5, Takeda G protein coupled receptor 5. Bile acids bind to these receptors, and there will be increase of the enzyme D2, which converts T4 to T3, and that is iodothyronine diiodinase, and so it will increase the, as you know, the thyroid hormones increase the basal metabolic rate, so there will be increased energy expenditure, so they can be useful in obesity along with type 2 diabetes. And in enteroendocrine cells, these TGR5 agonists increase the GLP-1 secretion. So these TGR5 agonists can be future drugs for diabetes. Bromocriptine is a dopamine 2 agonist, and based on the hypothesis that diabetics patients have low morning levels of dopamine, bromocriptine decreases lipolysis in adipose tissue, decreases hepatic glucose output in liver, and decrease insulin resistance in skeletal muscles. So they are used as anti-diabetic drug. Then renal glucose, after its filtration, it is again reabsorbed in the proximal tubule, both in convoluted tubule as well as straight tubule. In convoluted proximal tubule, 90% is reabsorbed, and in proximal straight tubule only 10% is reabsorbed. And the mechanism is through sodium glucose transporter 2 in the convoluted tubule, whereas SGLT1 is responsible in proximal straight tubule. So SGLT2 inhibitors are there, which can be used to increase the excretion of glucose in urine, so that the glucose load will decrease in the diabetic patient. Again, it is identified that SGLT1 is also present in intestine, and SGLT1 or 2 inhibitor, sotagliflozin, can have more advantages than SGLT2 inhibitors. Then there is a link between the inflammation and adipose tissue storage. The transcription link is there, and based on which the anti-inflammatory drug amlexanox is repurposed for its use against diabetes. Then live attenuated pneumococcal vaccine, it is found that the live attenuated pneumococcal vaccine increase the expression of programmed death ligand 1 PDL1, so it can be used alone or in combination with other drugs to cure type 1 diabetes mellitus, in which this PDL1 expression is decreased. Again, this in diabetes, this due to hyperglycemia, there is formation of amyloid products when the sugar molecules combine with proteins like albumin, and they result in advanced glycation end products which can cause vascular complications. So AGE receptor inhibitors can also be used to prevent diabetic vascular complications. And these diabetic vascular complications are also mediated by reactive oxygen species, which results due to activation of NADPH oxidase, which is activated through PKC pathway. So we can use PKC inhibitors or inhibit the NADPH oxidase activation. There are many natural herbs for treatment of diabetes, and many of them contains flavonoids, and some contain essential oils. And many more new concepts are there which are under trial and can be used as anti-diabetic in future. If we discuss the management, first there will be lifestyle modification. If that is not enough, then we can use the monotherapy metformin or sulphonylurea. Then we can combine them, metformin plus sulphonylurea or metformin plus any other drug, as dual therapy. Then if that is not sufficient, then we can use metformin plus sulphonylurea plus any other anti-diabetic oral drug as a triple therapy. And if that is not enough, we can add insulin and make it a more complex insulin strategy. So the search for anti-diabetic drugs will continue, and this will only end when we'll get a drug which can cure diabetes, not only treat the symptoms. Thanks.